Imagine standing at the precipice of a high-stakes moment, a patient's life, quite literally hanging in the balance of your next decision. For critical care paramedics, this isn't, hypothetical. It's a daily reality. And if you're laser focused on crushing the IBSC Critical Care Paramedic Board exam, this moment demands absolute mastery of airway management.
It really does. That foundational knowledge, combined with the ability to apply it flawlessly under immense pressure, that's what truly sets apart an expert in this field.
Yeah.
It's what the exam is designed to test and, honestly, what saves lives out there.
Today, we're taking a deep dive into the very core of that mastery: emergency airway management.
Okay.
Our primary guide, our sort of stack of sources for this deep dive, comes from the comprehensive Wall's Manual of Emergency Airway Management, 5th edition. This isn't just a textbook. It's packed with cutting-edge insights and even fundamental shifts in thinking that are absolutely critical for your exam and, even more importantly, for patient safety when you're out in the field.
Right. Our mission today is to sift through this dense, really rich material and pull out the most vital nuggets of knowledge, specifically for you preparing for that exam. We want to give you a clear, structured understanding of the latest evidence-based practices, the common pitfalls, and the nuanced decision-making you need for airway control in these really high acuity settings.
Yeah, focusing on those essential facts and maybe some surprising insights that will not only help you ace your exam, but crucially elevate your practice.
Exactly. Elevate your practice.
This isn't just about theory or, rote memorization, you see. This deep dive is about equipping you with the practical understanding and the confidence to assess, plan, and execute life-saving airway interventions.
Whether that's in the ED or, often for critical care paramedics, amidst the unpredictable challenges of the pre-hospital environment.
Definitely. Let's unpack this and get right into it. All right, so you're on scene, heart pounding, facing a critically ill patient who needs rapid airway intervention. Before you even think about reaching for a laryngoscope, what's the very first, almost sacred principle of emergency airway management?
Well, it's not really about being a hero, is it?
No.
It's about being a prophet. It's about anticipation and, above all, avoiding failure at all costs. Avoiding failure.
Yeah, this isn't just a nice to have. The Wall's Manual says it's the single most important way to prevent management failure.
You've hit on the absolute truth there. The ability to predict and prepare for a difficult airway is your primary defense. And the Wall's Manual makes a crucial distinction, and this is definitely something to, mark down for your IBSC exam.
Here, okay.
The difference between can't intubate, can't oxygenate, what we call CICO.
Brace CIC.
And can't intubate, can oxygenate. Understanding this difference is vital because their urgency and management implications are, radically distinct. They really are. When we talk about CICO, that's truly the ultimate nightmare scenario, isn't it?
Oh, yeah.
It means you're not just struggling to get the tube in. You can't even effectively bag mask ventilate or use an extraglottic device to keep those SATs up.
So what kind of timeline are we talking about in that moment? What's the immediate gut reaction it should trigger in a paramedic?
You're right. It's the absolute worst case scenario. Unlike can't intubate, can oxygenate, where you might have some, precious minutes to pivot to an alternative plan.
Right.
CICO is literally a matter of seconds. This patient will desaturate and die without immediate definitive airway management.
Wow.
There's no time to pause, no time for another attempt unless it's a completely different approach, like a surgical airway. It demands immediate, decisive action.
So if your one best shot at intubation in a CICO scenario fails, is your hand immediately forced to a surgical airway, or are there still any intermediate steps?
If you're truly CICO and your initial attempt at a definitive airway, let's say endotracheal intubation, fails. Yeah, you must immediately transition to the surgical airway.
Okay.
There isn't an intermediate step that buys you time if you genuinely can't oxygenate.
Right.
Contrast that with can't intubate, can oxygenate.
Right.
Here, you might not be able to intubate, but you can still get oxygen in using a bag mask or an EGD.
Okay, so you've got options.
Exactly. This buys you precious time to evaluate and execute various rescue options, making it a less immediate, though still really serious, crisis. It shifts from maybe a code blue to more of a code red, where you have a bit more runway to think and act.
This scenario is something every paramedic has faced or will face. That moment when, despite all your assessments, clinical conditions force your hand. Think of a combative patient, profoundly hypoxic, or just rapidly deteriorating, you're forced to act immediately, which means pushing those RSI drugs to create the best possible intubating conditions.
Yeah.
In these forced-to-act scenarios, that one best attempt at tracheal intubation becomes absolutely crucial, right? With immediate progression to a failed airway plan, if it's not successful, you need to be ready to transition.
And that perfectly segues into systematic airway assessment, which is truly your pre-intubation roadmap. Before you even touch a blade, you need a mental framework to predict difficulty.
Okay.
The Walls Manual strongly advocates for the Lemon mnemonic for difficult laryngoscopy. Even now, with video laryngoscopy everywhere, assessing for these factors is still essential for every patient where intubation is planned. Doesn't matter if it's pre-hospital chaos or the ED.
Let's break down Lemon, because you will absolutely encounter this on the IBSC exam. First, L-sense or look externally. What specific red flags are we visually scanning for here?
Okay, so you're scanning for visual cues that can directly impact your visualization and access during intubation. Think about things like a small chin we call micrognathia. That indicates limited space. A very large tongue or severely limited mouth opening are immediate red flags, almost like a door you can't quite get open wide enough.
Makes sense.
You also look for a short or immobile neck, maybe from arthritis or a C-collar, which can hinder proper positioning for direct laryngoscopy. Facial trauma, large incisors, that sort of truncal obesity, neck masses like goiters, or even radiation changes from past cancer treatment. All these can significantly complicate the procedure. They distort anatomy or just block your line of sight. It's all about spotting those anatomical barriers up front.
Before you commit. Then we move to E for Evaluate 332 rule. This is a classic foundational assessment, but what do those numbers really mean in practice, especially when you're under pressure in an emergency?
Yeah, the 332 rule gives you a quick, kind of approximate assessment of oral access and laryngeal position, a rapid functional snapshot.
Okay.
The first three refers to mouth opening. Ideally, the patient should be able to open their mouth wide enough to fit 3 of their own fingers between the upper and lower incisors.
Right. Their own fingers.
Yeah. This indicates adequate space for your laryngoscope blade or other devices. In an emergency, you're kind of crudely assessing, can they open fully, partially, or not at all? If they can barely open, you know you're in trouble.
And the second 3?
That assesses the mandibular space. You want 3 patient fingers between the mentum, the tip of the chin, and the hyoid bone, right at the chin-neck junction. Think of this space as where the tongue needs to go when you're trying to push it aside during direct laryngoscopy. If this space is really tight, maybe due to swelling from something like Ludwig's angina.
Oh, yeah. Nasty infection.
Yeah, that aggressive cellulitis of the floor of the mouth, it can make it incredibly difficult to displace the tongue and see anything.
And finally, the 2 in 332.
The 2 measures the hyoid to thyroid notch distance, ideally 2 patient fingers. Think of this as telling you how high up the voice box is positioned relative to the base of the tongue. If it's significantly less than 2 fingers, it might indicate an anterior larynx. Basically, the larynx is tucked way up high, almost hidden.
Makes it hard to see.
Exactly, a real challenge for direct line of sight, especially with a standard blade. If it's significantly more, the larynx might be too far down, needing maybe a longer blade.
Next in Lemon is M for Malampati score. We often think of this for the OR, cooperative patient sitting up. How does it apply in critical care and pre-hospital settings where your patient might be supine or out of it?
Yeah, that's a good point. While it's true Malampati traditionally involves a seated, cooperative patient, its core purpose is still relevant. Assessing the posterior oropharyngeal structures.
Yeah.
How much of the soft palate, uvula, tonsillar pillars are visible.
Right.
This gives you a general idea of the tongue size relative to the oral cavity, which does correlate with intubation difficulty. Class 3 and 4 Phi typically mean higher risk.
So how do you check it in an emergency?
Well, even with a supine or obtunded patient, you can get a crude Malampati assessment. Just examine their mouth with a tongue blade or even your laryngoscope blade before you fully insert it. The goal is just to get a sense of that mouth opening and the tongue's relative size.
Okay.
It's not super sensitive or specific on its own, obviously, but it adds valuable information when you combine it with your other assessments in Lemon. It's another piece of the puzzle.
Moving on to O for obstruction obesity. This seems pretty straightforward, but what are the key points the Walls Manual wants paramedics to really focus on for the exam?
Well, upper airway obstruction is a huge red flag. Think muffled or hot potato voice, inability to swallow secretions, or stridor, which is a particularly late and really compelling sign, especially in adults.
Right. Stridor is bad news.
Very bad news. Any of these directly increases the difficulty for everything. Bag mask ventilation, EGD placement, and definitely intubation.
And obesity.
With obesity, it's not just about the overall weight. It's about the excess fatty tissue in the pharynx, narrowing the airway, plus the sheer weight of the chest wall and abdominal contents restricting diaphragm movement.
Right, makes breathing harder.
Exactly. It significantly increases resistance, making all forms of airway management much more challenging. Walls also mentions the R in a refreshed Roman mnemonic for difficult bagging, which specifically adds radiation changes to the head and neck as a new important factor to consider.
Interesting addition.
Oh.
And finally, rounding out lemon, we arrive at N for neck mobility. It might seem obvious, but if your patient can't get into that optimal sniffing position, your challenges multiply, don't they?
Oh, absolutely. Limited neck mobility, maybe from a C-collar, severe arthritis, or other conditions like ankylosing spondylitis, is a major hurdle.
Why is that sniffing position so important?
Full cervical spine extension, or achieving that sniffing position, is crucial for aligning the airway axes, the oral, pharyngeal, and laryngeal axes. That alignment gives you the best possible view during direct laryngoscopy. If mobility is compromised, it significantly complicates the view and the whole intubation process.
Forces your hand to other techniques.
Exactly. You might have to rely more on inline stabilization or heavily lean on video laryngoscopy or use a bougie almost from the start.
Beyond just the anatomy, the Walls Manual highlights the critical importance of the physiologically difficult airway. What's the key distinction here, and why is it so crucial for patient safety, especially for the IBSC exam?
This distinction is absolutely critical for your practice and the exam. While anatomical difficulty refers to those structural barriers we just talked about, the physiologically difficult airway requires optimizing the patient's overall systemic condition before you even consider induction meds.
So fixing the bigger picture first.
Precisely. It means actively addressing critically low oxygen saturation, severe metabolic derangement like profound acidosis or significant hypotension. This is the entire concept behind that new pre-intubation optimization step in RSI. It's about maximizing cardiopulmonary physiology to create safer intubating conditions. That's a major shift in thinking, moving beyond just avoiding harm.
Okay, once you're actually performing laryngoscopy, you'll be assessing the glottic view using the Cormack-Lefane CL grading system. Can you detail these 4 grades and their significance, especially that nuance of 2A versus 2B, which seems like a classic exam point?
Certainly. This system categorizes how much of the glottis you can actually see during laryngoscopy. Grade 1 is your ideal view. You see pretty much the entire glottic opening from the front to the back cartilages. Correlates with almost guaranteed intubation success. You're looking right down the barrel.
The dream view.
The dream view, exactly. Grade 2 means you only see a portion of the cords, or just the arytenoids, those posterior cartilages. Now, this grade is further refined into 2A and 2B, and this is where the exam will likely test you.
Okay, 2A versus 2B.
Grade 2A shows any portion of the vocal cords. Crucially, a 2A view behaves pretty much like a grade 1 in terms of intubation success rates. You can usually get the tube in.
Okay.
Grade 2B, however, shows only the arytenoids, with no part of the vocal cords visible. The real nugget here for your practice and for the exam is that a 2B isn't just a slightly tricky view, it's a flashing red light.
Oh.
It tells you this airway will behave much more like a grade 3 airway in terms of difficulty. While it's only about 20% of grade 2 views, it's associated with difficult intubation in like 2/3 of cases. It demands immediate consideration of a bougie or a change in technique, not just another blind push.
Got it. 2B means think grade 3 difficulty.
Exactly. Grade 3 means only the epiglottis is visible. You see the floppy lid, but no part of the glottic opening itself. This is often prime bougie territory. Grade 4 is the worst possible view. No glottic structures are visible at all, maybe just the soft palate or the base of the tongue. You can't even find the epiglottis. This is where you quickly abandon that approach and transition to rescue strategies.
So if you're getting a 2B or worse, you know you're in for a significant challenge, and you need to be thinking backup plan immediately rather than just pushing through blindly.
100%. Adapt your strategy.
Now that we've assessed the airway, recognized potential pitfalls, the next critical foundation is preparatory oxygenation. Why is this non-negotiable for every emergency airway, especially pre-hospital where every second counts?
It's all about buying time, plain and simple. And this is a concept you must master for the IBSC exam. The primary goal of pre-oxygenation is to create an oxygen reservoir in the patient's lungs, blood, and tissues.
Like filling up the tank.
Exactly. Think of your lungs' functional residual capacity, the FRC, as your body's oxygen fuel tank. Normally, it's mostly nitrogen, like 80%. But with thorough pre-oxygenation, you're essentially flushing out all that nitrogen, filling the tank right to the brim with pure oxygen.
And that buys you.
That buys you precious minutes of safe apneic time, literally life-saving minutes, before the patient starts to desaturate during the intubation procedure itself.
Critical.
Especially crucial for patients who desaturate rapidly, like the critically ill or obese.
So the standard 3 minutes of 100% oxygen or 8 vital capacity breaths are typically recommended. But the Wallace Manual points out significant limitations, especially with standard non-rebreather masks outside the OR. Why is that?
Yeah, in the uncontrolled pre-hospital or busy ED setting, traditional non-rebreather NRB masks are often pretty rigid, they tend to have a poor seal, and they frequently suck in room air around the edges.
Right, leaks everywhere.
Yeah. This means they often deliver only maybe 50–65% FiO2, which is simply not enough for truly optimizing your critically ill patient. You need a much higher concentration to adequately build that crucial reservoir.
So what are the more optimized strategies for critically ill patients then to really pack that oxygen tank full?
Okay, first, flush flow rate oxygen. You can achieve nearly 100% FiO2 by just cranking the standard oxygen flow meter to its flush rate. That's usually over 40 Ls per minute, sometimes even up to 70.
Wow.
Yeah, through a standard NRB mask. This literally floods the mask with oxygen at a flow rate well above the patient's own breathing needs, actively preventing room air entrainment and ensuring a higher concentration gets delivered.
I've heard a lot about high-flow nasal cannula, or HFNC, for pre-oxygenation.
Right.
What are its benefits and how is it used here?
Yeah, HFNC systems deliver heated and humidified oxygen at very high flow rates, typically 30–70 Ls per minute. Their key benefits are washing out the upper airway dead space. That's essentially stale air that doesn't help with gas exchange.
Right.
Reducing the patient's work of breathing by providing all the flow they need and delivering a modest amount of PEEP, positive, and expiratory pressure, which helps keep the little air sacs open.
Yeah, it's more comfortable.
Exactly. The heat and humidification make these high flows much more tolerable for the patient over time. While its definitive role in pre-ox is still being sort of worked out, it shows immense promise, especially for patients who are still breathing on their own.
And what about non-invasive positive pressure ventilation, like CPAP or BiPAP? When should paramedics reach for that?
NIPTV, including CPAP, is strongly advocated for critically ill patients, particularly those in respiratory distress or with shunt physiology, like pulmonary edema.
Why is it better?
Because it provides a higher FiO2 through a tighter mask seal and actively promotes alveolar recruitment with PIP. It essentially pops open collapsed alveoli to allow for better oxygen exchange. It's especially important for patients who are difficult to pre-oxygenate.
Here's a technique that's absolutely crucial for every intubation and definitely something to remember for the exam. Apneic oxygenation. Can you walk us through it?
Yes. Apneic oxygenation is non-negotiable. It's a simple yet profoundly effective technique.
How does it work?
You place a standard nasal cannula underneath your main pre-oxygenation device, whether that's a face mask, an NRB, or a BVM. Run it at 15 Ls per minute or even higher during the entire pre-oxygenation phase.
And keep it on during the attempt.
Critically, yes. It remains in place and flowing throughout all intubation attempts, even while the patient is apneic. This continuous oxygen flow during apnea can significantly delay desaturation by using the phenomenon of oxygen consumption and nitrogen washout, allowing for passive gas exchange even without active breaths.
Buys you more time.
Buys you precious time during the most critical part of the procedure.
And for specific patient populations like morbidly obese patients or pregnant women, this is even more vital, right? They desaturate frighteningly fast.
Exactly right. Obese patients and pregnant women have a significantly reduced functional residual capacity, that smaller oxygen fuel tank we talked about,
right,
and increased oxygen consumption. This leads to much more rapid desaturation times. For instance, a term pregnant woman can desaturate to 95% in less than 3 minutes, compared to maybe 6 to 8 minutes for non-pregnant adults.
Wow, that's fast.
It is. Continuous nasal cannula oxygen is therefore essential for these patients to extend that safe apneic window as long as possible.
To truly know how your patient is doing, you need real-time objective feedback. That's where oxygen and carbon dioxide monitoring come in. Let's start with pulse oximetry.
Okay. Pulse oximetry provides that continuous, non-invasive measurement of arterial oxygen saturation, SpO2. It's critical for assessing oxygen delivery and the immediate effectiveness of your pre-oxygenation.
But it has limits, right?
Definitely. It's vital to remember its limitations. There's often a lag in peripheral readings compared to central saturation, and it can be unreliable in situations with poor perfusion, like severe shock or in hypothermia, because peripheral vasoconstriction messes with the signal.
So what's better for sick patients?
For critically ill patients, forehead reflectance probes are often preferred as they tend to maintain reliability better under those challenging conditions.
But the true gold standard, especially for confirming tube placement and something you will absolutely be tested on for the IBSC exam, is end-tidal CO2 EtCO2 monitoring or capnography. What's happening here physiologically and why is it so powerful?
Okay, so CO2 is a byproduct of systemic metabolism. EtCO2 monitoring reflects not just metabolism, but also pulmonary perfusion and alveolar ventilation. It's like having a real-time window into 3 crucial physiological processes simultaneously.
What about the different types? Colorimetric versus waveform?
Qualitative colorimetric monitors give you that simple color change. Purple to yellow indicates CO2, while quantitative non-waveform capnometers show a number, a partial pressure. But for the most comprehensive and reliable data, especially for paramedics managing critical airways, you need a waveform capnograph. It gives you the full picture.
What does a normal capnography waveform look like? And what can abnormal ones tell us, giving us those vital real-time clues?
A normal capnography waveform has that characteristic rectangular shape, right? Starting from 0 mmHg and returning to 0 mmHg during the respiratory cycle.
Okay.
If the Bettis line is elevated above 0, it immediately tells you there's CO2 rebreathing. That could be a problem with your ventilation circuit or maybe inadequate expiratory time leading to autopeep.
What about the shape?
A slurred upstroke, where the waveform rises slowly instead of sharply, suggests expiratory obstruction. You might see that in bronchospasm, COPD, or even just a kinked ETT. The plateau, which represents alveolar gas, should gently slope upward to the end of expiration, where the actual EtCO2 value is measured.
And for paramedics prepping for the IBSC exam, the clinical utility of capnography is beyond paramount, isn't it? It's not just a nice-to-have, it's basically non-negotiable.
Undeniably, it is the primary and most accurate method for confirming ETT placement. This is an exam cornerstone.
How does it confirm?
An absent or abnormal waveform immediately after a few breaths strongly suggests esophageal intubation, whereas a persistent, crisp square waveform for at least, say, 6 to 8 breaths definitively confirms tracheal placement.
And for extubation.
It's also the earliest and most reliable sign of accidental extubation, often showing up minutes before oxygen desaturation, giving you a crucial head start to fix it. Plus, it's invaluable for guiding ventilator management, troubleshooting issues like airway obstruction, and assessing how well you're actually ventilating the patient.
What about in cardiac arrest?
Good point. In cardiac arrest, the presence of a waveform confirms endotracheal intubation, but its absence can be indeterminate because CO2 production might just be too low due to poor perfusion. So you'd need alternative methods in that specific case, but otherwise it's your go-to confirmation.
So capnography isn't just a confirmation tool. It's a real-time feedback loop for the entire intubation and post-intubation process, letting you adjust on the fly.
Exactly. Indispensable.
Once you've assessed anticipated difficulty and pre-oxygenated, mastering basic airway interventions like bag mask ventilation or BMV is absolutely foundational. It's often an underestimated skill, but it can be a lifesaver, especially when definitive airways are proving challenging.
It truly is a fundamental skill that every paramedic must perfect. Optimizing BMV starts with effective airway opening maneuvers. In a patient without C-spine concerns, the head tilt chin lift is your standard approach.
But for trauma?
For anyone with a suspected C-spine injury, the jaw thrust is the safer, indicated maneuver. You forcibly open the mouth and pull the mandible forward, effectively creating an underbite, with your fingers carefully placed on the bony parts of the mandible to avoid squishing the soft tissue underneath.
And the sniffing position, that classic head tilt chin lift stance. What's that really doing?
That position, which combines extending the head back at the neck joint, the atlanto-occipital joint, with slight flexion of the lower neck, helps align those 3 axes: oral, pharyngeal, and laryngeal.
Okay.
This creates the straightest possible pathway for your laryngoscope blade and ETT, optimizing visualization, especially during direct laryngoscopy.
Beyond opening the airway, getting a consistently good mask seal and using proper holding techniques is critical for effective BMV, right?
Yeah.
That seems to be where many people struggle.
Absolutely. Optimal mask placement starts by seating the nasal part first, then the body of the mask, ensuring a good seal all around, and then releasing the cuff on your hand. Crucially, avoid pressing on the patient's eyes that can trigger vagal responses.
Two hands better than one.
The two-handed mask hold is demonstrably superior to a one-handed technique. It consistently delivers greater tidal volumes and allows for higher peak airway pressures if you need them. Your thumbs go on the mask body while your index, middle, and ring fingers curl around the angle of the mandible, lifting it and drawing the face into the mask to create that tight seal.
What about the single-handed EC grip? I've seen that used in practice, but often, with less success.
You're right, it's frequently taught, but it's often less effective. The E is formed by your bottom three fingers on the mandible pulling up, and the C by your thumb and index finger clamping down on the mask.
So why is it less good?
Well, it can be done if you're extremely short-handed, but it's fatiguing. It can easily deform the mask, making the seal worse, and it's generally less effective than a two-handed approach. The Wall's manual really emphasizes it should be a rare scenario.
Any tips for patients with no teeth?
Edentulous
Patients.
Ah, yes. For edentulous patients, a practical tip for improving the seal is to either leave their dentures in place if possible, that helps maintain facial structure, or if they're out, place the bottom edge of the mask cuff inside the lower lip on the alveolar ridge, using the gum line itself to create a better seal.
And what's the optimal ventilation technique with the bag itself? It's not just about squeezing hard and fast, is it? Seems like a common mistake.
Precisely. The primary goal is efficient oxygenation without causing gastric inflation. You achieve that by avoiding high airway pressures, which just force air into the stomach.
So slow and steady.
Yeah, that means longer inspiratory times, smaller tidal volumes, around 500 milliliters for adults, or really just enough to see gentle chest rise, and always ensuring those optimal airway opening maneuvers are maintained. Squeeze the bag with your hands, controlling the volume and pressure, not just mashing it with your arm or torso. Slow, deliberate breaths are key.
What about the Selleck maneuver, or cricoid pressure? It feels like this has been a source of a lot of debate, and its role has really evolved, maybe even disappeared.
You're absolutely right. It's highly controversial now. Historically, it was taught religiously as a way to reduce gastric insufflation and aspiration risk by supposedly occluding the esophagus.
But does it work?
Well, recent high-quality evidence suggests it may not reliably occlude the esophagus, and critically, it can even impair ventilation by obstructing the glottic opening or actually worsen the laryngoscopic view.
So optional now.
The Wall's manual states it's now considered optional and should only be performed if personnel are available and well-trained, as its benefits are debatable and definitely not consistently proven. For your exam, understand its history and its current, very diminished role. Probably best avoided unless specifically trained and indicated locally.
Moving on to extraglottic devices, or EGDs. These seem to be gaining prominence as vital bridging tools in emergency airway management, particularly pre-hospital.
Yes, EGDs have an expanding and increasingly critical role. They are primarily airway rescue devices when bag mask ventilation is difficult and intubation has failed, especially in a CICO situation, buying you critical time.
Easier than bagging sometimes.
Definitely. They also serve as an easier alternative to BMV for basic life support providers, and can even be an alternative to endotracheal intubation in some cases, or act as a conduit to facilitate intubation when direct visualization is tricky. Their relative ease of insertion and reliable oxygenation make them invaluable.
What are the main types of EGDs paramedics should be aware of, especially for the IBSC exam?
Okay, the most common are from the laryngeal mask airway, or LMA family. The LMA Classic is the original, right? Inflatable elliptical cuff, seals around the top of the larynx. The LMA ProSeal and LMA Supreme are second-generation devices. Big advantage. They have a drain tube for gastric access and decompression. That helps manage aspiration risk. They also have an enhanced seal. The Supreme is also rigid, which can make insertion easier.
And the intubating LMA.
Right. The LMA Fast Track, or intubating LMA, ILMA, is crucial for its specific purpose. It has a handle for positioning and boasts really high blind intubation success rates, often over 90% first pass, because it's designed to guide an ETT right through it.
What about the iGel?
The iGel is another popular one. It's cuffless, preformed, and also has an esophageal drainage tube. Its anatomical shape often makes it very easy to insert quickly.
And the King LT. That's a really common one in pre-hospital care.
Yeah, the King LT is a retroglottic device, sits behind the glottis, inserted blindly into the esophagus. It has a single port to inflate balloons that seal both the esophagus below and the pharynx above.
Any tips for using it?
A key nuance with the King LT, something to remember, is to withdraw it 1 to 2 centimeters past the first sign of ventilation. That ensures optimal lung-directed flow. If you stop too soon, you might still direct air into the stomach or not get great ventilation.
Once an EGD is in place, how do you manage the patient? It's not always about immediately swapping it for an ETT, is it?
Correct. Your initial focus should always be on confirming placement and optimizing gas exchange. EGDs are reliable ways to oxygenate and ventilate, even if they aren't technically definitive airways.
So stabilize first.
Often, yeah. Critically ill patients might have other urgent priorities needing imaging, procedures, or just stabilization before a long transport. If the EGD is working well, maintaining good sats and ventilation, you can often safely defer immediate ETT exchange. Buys you critical time to address other issues or talk to receiving providers, like anesthesia or the OR team.
But if you do need to exchange an EGD for a definitive ETT, what are the main techniques?
Okay, one key technique involves using an Aintree catheter or airway exchange catheter, AEC. This is basically a hollow bougie designed to fit over a flexible endoscope or just used as a wire guide.
How does that work?
You insert it through the EGD into the trachea, carefully remove the EGD while the AEC stays in the trachea, and then pass an ETT over the AEC. The AEC itself even has a connector, usually a 15-millimeter one, so you can provide rescue oxygenation through it if you run into delays getting the tube passed. That's a critical safety feature.
Any tricks to passing the tube over it?
Yeah, when passing the ETT, sometimes using a Macintosh blade just to lift the tongue and keep pressure off the Aintree can prevent it from kinking and make the tube slide down more smoothly.
And what if it's a retroglottic EGD like the King LT? Can you intubate around those?
In those cases, you can sometimes intubate around them. You basically sweep the EGD way over to the side of the mouth to make room for laryngoscopy, often using a standard geometry video laryngoscope and maybe a tracheal tube introducer, like a bougie.
Anything else to consider?
Because many of these second-gen EGDs have gastric drainage channels like the ProSeal or iGel, gastric decompression should happen whenever possible before you start manipulating the airway for intubation, just to reduce aspiration risk.
This all really speaks to the importance of having multiple tools and techniques in your airway toolbox and knowing exactly when to use which one based on the situation.
Couldn't agree more. Flexibility and backup plans are key.
Now, let's dive into the core process that defines advanced airway management for paramedics. It is really a centerpiece of the IBSC exam. Rapid sequence intubation, or RSI. The Walls Manual outlines the 7 Ps of RSI as a systematic step-by-step approach.
This is absolutely fundamental. RSI is a series of discrete, yet often simultaneous steps designed to create the best possible intubating conditions while critically minimizing the risk of aspiration. It's a carefully choreographed process, and each P is vital. You have to know these inside and out for the exam.
Let's break down each of the 7 Ps, starting with 1. Preparation. This goes way beyond just grabbing your equipment, doesn't it?
Oh, absolutely. Preparation is extensive, and it's foundational to success. You thoroughly assess the patient for anticipated difficulty using tools like Lemon, and you mentally run through your backup plans, your plan B, C, D for failed intubation scenarios.
What else?
You ensure your resuscitation area is organized. Vital sign monitoring is crucial. Cardiac monitor, BP cuff cycling, pulse oximetry, and critically continuous waveform capnography is set up and ready before you start. 2 secure IV lines are ideal, 1 for drugs, 1 for fluids or pressors.
And the meds and gear?
All pharmacologic agents must be pre-drawn and clearly labeled to avoid disastrous medication errors. And critically, all vital equipment, your laryngoscope light checked, ETT cuff tested, stylet in, bougie handy, video laryngoscope turned on, and screen clear if you have one must be checked for proper functioning. And throughout this whole phase, you are continuously pre-oxygenating and optimizing the patient. Think of it as a pre-flight checklist for a high-stakes mission.
That leads directly to 2, pre-oxygenation, which we just covered in depth. But it bears re-emphasizing its specific role within the RSI sequence itself.
Precisely. Pre-oxygenation is essential to the traditional no-bagging principle of RSI, which aims to reduce gastric insufflation and aspiration risk. Its goal is to create that oxygen reservoir, primarily in the FRC, allowing for several minutes of apnea without desaturation during the attempt.
So, same methods.
Yeah, we reinforce the standard of 100% oxygen for 3 minutes or 8 vital capacity breaths using the best available device. And as we discussed, apneic oxygenation via nasal cannula at 5 to 15 liters per minute or higher continuously throughout the entire sequence is crucial for mitigating desaturation, especially in those patients predicted to desat rapidly, the obese, the pregnant, the critically ill. Don't forget the nasal cannula.
Here's one of the truly transformative changes in the Walls Manual, and this is absolutely critical for the IBSC exam. 3. Pre-intubation optimization. This replaces the old pre-treatment step. Why the shift, and what does it fundamentally entail? This feels like a big deal.
It is a significant evolution, yeah. Based on new evidence regarding the profound hemodynamic consequences of RSI in critically ill patients, the shift away from pre-treatment acknowledges that many previously advocated agents, like lidocaine for ICP or reactive airway disease, frankly lacked high-quality evidence for their benefit.
And sometimes caused harm?
Or just introduced inefficiencies or risks. The core of pre-intubation optimization is a fundamental paradigm shift. We're moving beyond just avoiding harm to actively building resilience in the patient before we even touch the paralytic.
Building resilience, I like that.
It's about recognizing that in a crashing patient, the induction itself can be a physiological cliff edge, and our primary role is to fortify them, not just medicate them with questionable pretreatments.
So it's about making the patient as physiologically robust as possible, optimizing their vitals, correcting metabolic derangements before you hit them with paralytics and sedatives, which can worsen things.
Exactly. You're identifying and actively mitigating cardiopulmonary vulnerabilities. Things like hypotension, severe hypoxemic respiratory failure, or significant metabolic derangement like severe acidosis. This means actively intervening before induction.
Like what?
Administering isotonic fluids, blood products if indicated, starting or titrating pressor agents like norepinephrine for hypertension. You're also escalating oxygenation efforts if needed, using all those tools we just discussed, HFNC and IPPV. For example, if you suspect a tension pneumothorax, you're performing a needle decompression or placing a chest tube before you intubate.
What about things like fentanyl?
Sympatholytic options, like fentanyl, if the patient can tolerate a blood pressure drop, are now considered part of this holistic cardiovascular optimization to blunt the sympathetic response, not an independent pre-treatment step. And importantly, lidocaine is now removed from the lexicon for this purpose due to lack of evidence for routine use.
Okay, big change there. Once that optimization is as complete as possible, we move to 4, paralysis with induction. This sounds like a rapid, synchronized step, a true push and go.
It is. This involves the simultaneous 5E push administration of an induction agent immediately followed by the paralytic. The goal here is to rapidly achieve both unconsciousness and complete muscle relaxation to create those ideal intubating conditions. It's a precisely timed sequence. Push sedative, push paralytic, boom.
And it's time for 5, positioning. You've administered your drugs, the patient is relaxing, and now you're literally shaping the patient for success.
Yeah, about 20-30 seconds after the drugs are pushed, as the patient becomes apneic and flaccid, you position them optimally for laryngoscopy.
Sniffing position.
Usually the sniffing position to align those airway axes, but always with careful consideration for cervical spine immobilization in trauma patients. Maintain meticulous inline stabilization if needed. Ensure the bed height is right for you, the operator, for comfort and leverage.
And the apneic O2.
Critically, the nasal cannula used for apneic oxygenation remains in place and flowing at 5-15 Eulers per minute throughout the entire intubation attempt. Don't take it off.
Megan.
Bag mask ventilation is only performed immediately before laryngoscopy if the patient is profoundly hypoxemic and requires it, and not between attempts if saturations are maintained to avoid that gastric insufflation. The Selleck maneuver, as we discussed, is now optional and its application remains controversial, but if used, it's during BMV for unresponsive patients.
After positioning, we get to the moment of truth. 6, placement with proof. You've got the tube in, hopefully, but that's only half the battle. Proof is paramount.
This is when you perform the intubation after ensuring the mandible is completely flaccid and the patient is fully relaxed. But placement alone isn't enough. Definitive proof is mandatory, and continuous waveform capnography is the absolute gold standard for confirming ETT placement. End of story.
Not colorimetric.
While qualitative colorimetric detectors exist, they are significantly less reliable, especially in cardiac arrest where CA2 production might be too low for a color change. They can give false negatives or positives. Waveform is king.
What are you looking for on the waveform?
You expect a persistent square waveform for at least 6 consistent breaths. That definitively confirms tracheal placement. An absent or abnormal waveform immediately indicates esophageal intubation. Capnography also serves as the earliest sign of accidental extubation.
Any other confirmation methods?
Suction esophageal detection devices exist like a piston syringe or self-inflating bulb, but they're less common now than capnography, which is clearly superior for reliability.
Finally, after a successful intubation, it's 7, post-intubation management. This isn't just a simple wrap-up. It's a critical phase for the patient's long-term outcome, right?
Not at all. This phase is incredibly critical for patient outcomes and preventing secondary injury or complications. The priority immediately post-intubation is establishing effective long-term sedation and analgesia.
Lib agents.
Propofol is often the agent of choice for ongoing sedation due to its rapid recovery and titratability, paired with an analgesic like fentanyl to manage pain and the discomfort of the tube.
Keep them paralyzed.
Neuromuscular blockade should only be continued if medically indicated for patient control, like in severe ARDS or for specific diagnostic purposes, and not routinely just because they're intubated.
Why not?
Prolonged paralysis has its own morbidities like critical illness myopathy and neuropathy. Sedation scales, like the Richmond Agitation Sedation Scale, RASS, should be used to guide decision-making and prevent unnecessary or prolonged paralysis. Titrate sedation to a goal. Don't just know them if you don't have to.
So understanding these 7 Ps in detail, especially that profound shift to pre-intubation optimization, is absolutely paramount for anyone preparing for their IBSC Critical Care Paramedic Board exam. It's not just a checklist, it's really a philosophy of safe airway management.
Exactly. It's the framework.
A huge part of successful RSI, and another critical component for your IBSC exam, is understanding the pharmacology of RSI. Let's start with the induction agents. These are the drugs that rapidly induce that critical state of unconsciousness needed for paralysis.
Right. These are the agents that put your patient to sleep quickly and reliably, allowing the paralytic to work under safe conditions. Etomidate remains a standard choice for RSI, largely because it causes the least hemodynamic variation, minimal effect on blood pressure and heart rate.
Good for shocky patients.
Generally, yes. It's usually safe for patients with precarious cardiovascular status, like those in shock. It gets to the brain reliably, even in sepsis, making it a very predictable agent. Ketamine is excellent, especially for hemodynamically compromised patients' sepsis, shock, because it has those sympathomimetic effects. It actually increases heart rate, blood pressure, and cardiac output.
What about head injuries? Used to be a concern.
Yeah, the thinking has shifted. There's increasing evidence supporting its safety in brain-injured patients. It helps maintain cerebral perfusion pressure by maintaining MAP, and it might even have some neuroprotective properties. So if your TBI patient is hypotensive, ketamine is probably your best friend. Propofol offers rapid recovery, which makes it often the agent of choice for ongoing sedation after intubation. However, the big caveat is that it can cause significant hemodynamic depression, major drops in blood pressure.
So be careful with it for induction.
Very cautious, especially in unstable patients. It's generally not a first-line induction agent in emergency RSI unless the patient is hypertensive or you have pressors immediately available. Midazolam is an alternative, a benzodiazepine, but it generally has a slower onset and can cause more significant hypotension compared to etomidate or ketamine, especially in compromised patients. It often functions pretty poorly as a primary RSI induction agent in the emergency setting. Better for post-intubation sedation, maybe.
And what about dosing these agents, especially in patients with varying body weights, like the morbidly obese? That's a common challenge in the field and probably an exam point.
Yeah, dosing is key. For non-obese adults, the general rule is ideal body weight, IBW, though total body weight, TBW, is often used as a close enough approximation in practice. For morbidly obese patients, it gets more complicated because of how drugs distribute in fat versus lean tissue.
So what's the rule for obesity?
For agents with significant hemodynamic depression like propofol, the Wall's manual suggests using lean body weight, LBW, maybe even decreasing to IBW if the patient is hemodynamically compromised. You want to avoid overdose and subsequent hypotension. This is definitely an area where specific guidance, like in the Wall's manual, is crucial.
Now, to the neuromuscular blocking agents, or NMBAs, these are the cornerstone of RSI because they provide that essential paralysis. But what's their fundamental function and what don't they do? A critical distinction for paramedics in the exam.
Their function is purely to provide complete muscle relaxation, making intubation easier and safer. However, and this is a critical exam point and safety issue, NMBAs do not provide any analgesia, sedation, or amnesia. They just paralyze.
So always give sedation first.
They must always be paired with a sedative induction agent. An inadequately sedated but paralyzed patient is experiencing a nightmare scenario. They are aware but completely unable to move or signal distress. Always ensure your sedation is working before your paralytic takes full effect.
Let's talk about succinylcholine first. It's known for its rapid onset, making it a popular choice historically.
Yeah, SD is a depolarizing NMDA. Very rapid onset, typically under 60 seconds, and a nice short duration of action, usually 5–10 minutes. For optimal intubating conditions, the recommended dose is 1.5 milligikilogram or even more.
How do you dose it in obesity? This seems counterintuitive.
Right, here's a key distinction for the exam. For succinylcholine, even in morbidly obese patients, we actually dose it based on total body weight.
BBW.
Why TBW for S? Because obese patients actually have more of the enzyme pseudocholinesterase. That breaks it down. So a bigger person needs a proportionally bigger dose to get that same rapid, profound paralysis. Doubling the dose only adds about 60 seconds to its duration, so it's more about achieving optimal paralysis quickly rather than trying to prolong it significantly.
But SG carries a significant risk, hyperkalemia. When is it absolutely contraindicated, meaning you should never, ever use it? This feels like a major safety point for the exam.
It absolutely is. ESHI is absolutely contraindicated in conditions that cause upregulation of extrajunctional acetylcholine receptors. This leads to massive potassium release when ESHI hits those receptors, potentially causing life-threatening hyperkalemia and cardiac arrest.
What conditions specifically?
This includes Bushins, typically after 35 days post-bone and lasting until healing is complete. Denervation injuries like spinal cord injury or stroke, usually from about 3 days to maybe 6 months post-event as those extra receptors proliferate. Progressive neuromuscular disorders like multiple sclerosis or ALS, where patients are perpetually at risk. Certain congenital myopathies, which are an absolute contraindication due to the risk of rhabdomyolysis and hyperkalemic arrest.
What about eye injuries?
While ST has been linked to increased intraocular pressure, there are no reported cases of vitreous extrusion in open globe injuries, so Wall still recommends it in that context if otherwise indicated, and rocuronium isn't readily available or preferred. But those hyperkalemia risks are absolute no-goes.
So if SC is contraindicated, what's the alternative then? Rocuronium.
Rocuronium is your go-to alternative. It's a non-depolarizing competitive NMDA. For RSI, the recommended dose is 1.0–1.2 milligaussive kilograms. This higher dose provides intubating conditions truly equivalent to SE in terms of speed and quality of paralysis.
Onset and duration.
Onset is 60–90 seconds, so very similar to SEO at that dose. But its duration is significantly longer, typically 40–60 minutes. That demands careful planning for post-intubation sedation. You can't let them wake up paralyzed.
Advantages over SE.
Importantly, rocuronium does not carry the risk of hyperkalemia or elevation of intracranial pressure. And like SG, it is also dosed on total body weight, TBW for RSI, in obese patients to ensure adequate paralysis.
And finally, a quick note on defasciculating doses before SESHI. Still a thing.
Nope. The Wall's manual is clear. Defasciculating doses previously given before SG to try and reduce muscle twitches are no longer recommended. Lack of demonstrated benefit, potential for prolonging onset. Just skip it.
What about topical anesthesia and airway management? When might paramedics use this?
Topical anesthesia, usually with lidocaine, is primarily used for awake intubation techniques, allowing the patient to remain cooperative while you numb the airway structures.
How do you apply it?
Methods include spraying it, nebulizing the agent, or sometimes direct tracheal injection via cricothyroid membrane puncture. For nasal intubation, local vasoconstriction with agents like phenylephrine or oxymetazoline can help reduce bleeding and improve your view.
Is lidocaine still used as a pretreatment in RSI?
Important point. Lidocaine is no longer recommended as a pretreatment agent for patients with elevated ICP or reactive airway disease for routine RSI. The evidence just doesn't support its efficacy for those indications anymore. Stick to optimizing the patient and choosing the right induction paralytic combo.
So a lot has changed in the pharmacologic approach to RSI, all geared towards safer, more effective intubations and reflecting the latest evidence for paramedics preparing for their boards. It's crucial to be up to date.
Absolutely. Evidence evolves and practice has to evolve with it.